And as some of them have come to me after they're finished or even during the program, and they've said, not only have I helped to further develop their careers, but I've changed their lives and made their lives better, the way they interact with people personally. And to me, that's what legacy really is.
Hi, everyone, and thank you for listening to our podcast. Today, I'm speaking with Michael Guertin, Chief Perioperative Medical Director at the Ohio State Wexner Medical School. Michael has a rich history as a clinician and as a physician leader. He's dedicated 3 decades of his life to physician education and has expertise in anesthesiology, healthcare management, and leadership development. Michael, such a pleasure to have you on the show. Before we dive deep into the episode, could you tell us a bit about yourself?
Yeah, thank you, Ohad. I am, as you said, an anesthesiologist. I went to medical school and undergrad in Detroit at Wayne State University. I came to Ohio State back in 1988 to do my internship and residency. I ended up staying at the university for 10 years, and then I had the opportunity to do something at the time that was very innovative, which was help to start a physician-owned ambulatory surgery center. And we were actually the first physician-owned ambulatory surgery center in Central Ohio. I was there for 15 years, and it was really a wonderful adventure, and very proud of the patient care that we delivered and some of the advancements that we helped to further in ambulatory surgery. For example, we were featured in the local news a couple of times for some of the innovative technologies we were using, one of them being BIS monitoring, which monitored brain waves that told us how deeply anesthetized somebody was, also using video laryngoscopy and having it immediately available back in the early 2000s when that technology first came along. So really had a wonderful time with that. When my youngest child graduated from high school and went to college, I decided I'd go back to college too. So I went to Ohio State and got my MBA. That was a 4-year journey in a part-time working professional MBA program. And in the middle of that, I was offered an opportunity to come back to the university in a leadership role. I came back as the physician medical director of ambulatory surgical services. And then during the pandemic, with all of the changes that occurred, a new role was created, and I became the chief perioperative medical director for the medical center, which allows me to manage and help really facilitate care of patients across over 90 ORs at this point, in over 8 sites and more being built. So really has been a wonderful adventure. Along the way, 5 years ago, I became the director of the Faculty Leadership Institute leadership part of our faculty advancement, mentoring, and engagement, FAME, in the College of Medicine. And I now direct that leading development of leadership for faculty members in all 7 of our health science colleges. So that's what got me to this point.
That's a lot. Wow, a lot to unpack there. I'm always really interested by the background of people like you that start with a clinical background and are drawn to leadership and are drawn also to the administrative side, kind of sometimes what comes across as the dark side of healthcare. So really interesting how you've synthesized that through your career and also had, sounds like a pretty substantial period as an entrepreneur setting up this ambulatory surgical center. That's a business, in addition to it, and serving as a clinician there. So would love to come back to some of those points, but maybe first starting off, what drew you into medicine? What was enticing about this field?
That's a very interesting question. My mother, God rest her soul, was a CRNA, a nurse anesthetist, for over 44 years. And so I grew up in that environment. My father was an electrician, worked for General Motors. So it really was a diverse type of professional home environment background that I grew up in. Mm-hmm. And quite frankly, I think both of my parents really wanted to dissuade me from going into medicine because they saw how challenging it was and how difficult it was. But it was something that I was drawn to. And I had a hockey injury when I was in high school, so I spent a fair amount of time in hospitals and undergoing surgery. And I don't know if that really sparked it even more. I think it probably did. But when I got to college, quite frankly, getting into medical school was one of the most challenging things. And that was a challenge for me.
Mm-hmm.
And so I sought that out, and that's what drew me into medicine. And I could not have made a better choice career-wise that really fit all the skill sets that I feel like I have and the opportunities it's given me to really meet and care for such an incredibly diverse group of people. And I really feel blessed to have had the career that I've had.
Well, we're lucky to have people like you in the healthcare system. And so you're starting out your career as a clinician, and then you decide to make this jump, moving out of hospital care to open an ambulatory surgery center, which I'm guessing back in the day was still relatively early. Now they're quite common, and we're seeing a lot more of a push of trying to move procedures out from the hub to the spokes, to the ASCs. But back in the day, that was pretty novel. What was that like, trying to create more of a consumer-driven environment, right? Because in the ambulatory setting, all of a sudden, it's not an inpatient ward, and you're dealing with patients quite differently. Tell me about that and setting up that business.
Well, you have a lot of insight just from the way you asked that question, and I appreciate that. If I knew then what I know now, I probably wouldn't have taken that risk. But I was, as I like to say, I was young and dumb and adventurous, and we had an opportunity. We had some physicians who had been physicians for quite a while, surgeons, and a number of us younger physicians who they encouraged to join them in this venture. And it really turned out to be something that, and I always tell people, life is what happens when you're busy making plans. And when I finished residency, though a couple of our colleagues that went into ambulatory surgery centers, we thought, why would you waste all this training going into doing ambulatory surgery? Because at the time, in the early 90s, it was very simple surgeries and only very healthy patients. It was in the beginning. And when I went into that, it was really, I did it, quite frankly, to be very honest, I did it so that I would have more time with my family and be able to raise my daughters at that time, because it would give me more time away. And what I really learned was that it was the career path that would lead me on the career path that has led me to all of this leadership. So it was really a very interesting time when we focused really very much on very high patient quality care and high efficiency. And we were very, very efficient. We were doing the most surgeries of any ambulatory surgery center in the country, given the number of ORs we had at the time when we got going. And it was in the infancy of that industry. So it was really, when I look back on it, it was, again, something that I could not have planned and didn't plan. And it's turned out to be really a career path.
Yeah, I think that's a direction that I'd love to explore further later, maybe in this interview, because, you know, as we deal with some of, especially the post-COVID kind of congestion we're seeing in the ER, in the OR, wait times, backlogs, you know, part of I think the promise of where healthcare is going is to untangle some of that by moving more and more procedures to an ambulatory setting and empowering physicians to be able to do more complex procedures outside of a hospital environment. That's also, by the way, a big focus for my company from an ultrasound perspective. How do we move imaging from something that's buried in the basement of the hospital to something that's accessible at the bedside, at the point of care? But maybe before we come back to that, just to kind of finish rounding out your career journey. So from this very interesting venture, 15 years of leading an ASC, you come back right to the mainstream of healthcare, but you take a different tack. You now focus on leadership. And that's a topic that, again, isn't often discussed of the role as clinicians and physicians as being leaders. And just in our prep for this interview, you talked to me about a lot of competencies that are not often thought of as things that physicians should spend time on, like, for example, coaching and being coachable, communication skills. Maybe talk to me about, and talk to our audience about, kind of how you saw this calling for synthesizing, you know, your clinical background and your kind of this higher purpose of leader and leadership and inspiring other leaders to follow your journey.
You know, the kind of the sentinel event that I always think back that occurred a number of years ago when I was in the surgery center, still in private practice. I had an interaction with a nurse that I didn't think anything about, but apparently and clearly it upset her with the way that I approached it. And that night I got a call from a friend who happened to be the chairman of the board, and he asked me if I was okay because I had really upset this nurse and it was unlike what I had done. And I remember thinking very clearly, I can make one of two choices. I can either say, that person needs to basically just get tougher and do their job right. Or what I chose was to become more self-aware and realize that as physicians, and particularly as physician leaders, because I was the medical director at the time, we have a higher duty to make sure that the way we conduct ourselves really helps to empower, engage, motivate everybody on the healthcare team. And that was a decision I made in that moment. And it really led to really the rest of my career. And a couple of years ago on her birthday, I called her, we talked about it, and she actually was in tears thinking that she had that kind of an impact on my career. It was a really sentinel moment. And again, I remember it very clearly. But from that, I got a very good coach who was recommended to me by another physician leader who was a CEO. That coach helped take me to that next level of self-awareness, self-development. I also have to say, I have to give credit to a Supreme Grandmaster, Jun Che, who was my Taekwondo mentor. Mm-hmm. And he really helped me to learn so much about life and how to conduct myself and how to become better and always improve. So I've been very, very, again, fortunate and blessed to have very good people that I've come across in my life almost by accident, but have really had a profound influence on me.
That's just such a fascinating perspective, right? Physicians as leaders. And of course, naturally they are. We look up to them. They're making life-changing decisions for us. We're taking advice from them. And I think that having that lens, that self-reflection to look in the mirror and say, we have to own that leadership role in terms of how we lead the team with nurses, other physicians, techs, the support team around us in terms of how we lead the conversation with patients. I know you've been leading this Atlas program, if I have that right, which is focused on progression of skills for physicians. This is something you're doing through Ohio State, right?
In the College of Medicine, as I said, I'm the director of leadership in our Faculty Advancement Mentoring Engagement Center. Atlas is my next program. I'm still developing that. That still has not started yet. I lead the Faculty Leadership Institute now. That was started 12 years ago in the College of Medicine, and I assumed the role of leadership in that 5 years ago. And I grew it from the College of Medicine to include all 7 of the health science colleges. And it really has given me an opportunity to continue my own personal development, but more importantly, really, again, very significantly have a profound impact on other people's career development. And as some of them have come to me after they're finished or even during the program, and they've said, not only have I helped to further develop their careers, but I've changed their lives and made their lives better, the way they interact with people personally. And to me, that's what legacy really is. And building that legacy is so critical as we get further in our career, because you do so many other things. But this is really where I feel that I have made a significant contribution to the future, is by helping other people develop their leadership skills and become leaders. And you mentioned one thing that I'd like to just real quickly comment on too, that I really learned along the way and really believe in. You said coming into the dark side of leadership and administration. And I think that for too long, there was that schism between physicians and administrative leaders. And again, I feel really fortunate to be on a team with very, very good leaders, from our CEO, who is a physician, but our COO, many of our executive directors, our chief administrative officers, really be on a team of people that really collaborate, respect, and work very well together. And I think that's a really important thing, that we don't look at what we don't feel are the equivalents of us, because we have a lot of clinical knowledge, but they have a lot of administrative knowledge. If we can bring those together and synthesize those, that's better for our patients and better for our organization. So it's really important that we don't have that divide between us.
Exactly. And I think it's people like you who are speaking out also about it that is kind of making that schism go away, right? Lowering that hurdle rate, that barrier between administration and clinician and the clinical domains, and allowing you to cross over much more seamlessly. So you're investing a lot of your time, a lot of your energy in building this amazing legacy of leadership in the clinical domain and in also the administrative sphere. How is that preparing the future physicians and the staff also at The Ohio State to get ready for for the challenges of healthcare? Like, how do you apply where does the rubber meet the road of building this kind of skill development and competency faced with all of the challenges that healthcare faces? And maybe talk to me a little bit about also how you see those challenges, because a big theme for our podcast series is disruption, is how do we bring creative ideas to solve challenges that we face within the healthcare space?
Well, first of all, I've really developed our Faculty Leadership Institute along the lines of developing relational skills. And oftentimes they're referred to as soft skills, but I don't like that term because I think it devalues how important they really are. And there was an article in the Harvard Business Review back in December of 2017 that really focused on what are the skills that physician leaders need as they ascend leadership ladders. And relational skills are obviously a very important part of our clinical training and our clinical work life, and the relational skills with patients and with the team that we lead as physicians. But as we ascend that leadership ladder, they become even more important, because it really is important that we're able to communicate the messages that we feel are important. As new technologies become, how do we then engage people? And first of all, this is all change management. Innovation really involves change management on a very dynamic scale. And first, it's very important that you can communicate to create a compelling vision for what you see as that change that's occurring and needs to occur, creating a sense of urgency so other people understand we really need to do this. It's really important. And then developing a coalition of the teammates. And again, that's administrative, it's staff, it's all roles, all different types of stakeholders who you need to communicate with effectively, and again, communicate that vision and that sense of urgency. And then you need to be able to collaborate and communicate with your administrative leaders to create a good business case, because while the mission is more important than the margin, as a physician, as a clinician, if you don't have a margin, you don't have a mission, because you can't keep the doors open. So it's important to create a good business case for all these technologies, and then to continue as you have small wins along the way to communicate those and create this proof of concept that, yeah, this really is something that's important, both from a clinical standpoint and from a business standpoint. And there are a number of instances we can think of that. Robotics is one that now is becoming the standard of care, and it is very expensive now, but as it becomes more and more in the mainstream, it becomes the standard of care. That will drive a lot of that innovation. Another one that we've talked about is point of care ultrasound. Very important technology that's come along that allows us to really better care for patients. For example, as an anesthesiologist, if somebody maybe isn't sure if, what they had if they ate something or they drank something and they're not really sure about the timing of that, rather than just canceling their surgery, we can do a very quick point of care gastric ultrasound and see, is there something in their stomach? If there is, then we can delay their surgery so that we don't increase the risk of aspiration. If the stomach is empty, then we go ahead and care for them. And that's really what we should be trying to do. So again, these kinds of things, point of care ultrasound, giving us the opportunities to improve patient care. And it's innovation that has a cost associated with it, but the effectiveness and the patient care that it drives that margin as well. So again, these are all the points that are really important as physician leaders, that we partner with all of the stakeholders that we come in contact with.
I think the way you laid that out, Michael, is so clear. I honestly hope that every medtech CEO listens to that blueprint, that playbook of how to manage change. Because to me, just like you said, often introduction of new technology is really a change management exercise, and understanding how to do that along those 5 or 6 steps that you articulated is really a key to success. I think also, maybe to add to that, it first has to come from a profound understanding of what is the problem that we're solving. I think often, we're faced with so many challenges in healthcare. It's actually difficult sometimes to right size and pinpoint to say, here's the problem I'm trying to solve. And often, especially as technology CEOs, we get enamored with a solution. So we become solution centered. I've got a better mousetrap, here it is. And then the clinical team is saying, I'm just not sure really what problem you think this solves. And so really understanding that, I think, is the key to nailing the workflow and then following those change management steps that you discussed. And I also loved how you talked about the yin and the yang of the mission and the margin. And it's something that, we also on the private sector side, right, of the vendor side, we have to think about as well, because, nobody starts up a digital health or a med tech company only for the margin. There's easier ways to make money. You could be in crypto, you could be in fintech, right? This is a tough industry. So there's always going to be a mission component, even if you're on the vendor side. And just remembering what that is and tying that into kind of the mission and the margin working lockstep is so important, I think, for both sides of the coin, both the providers that are buying technology as well as vendors that are selling it.
Again, that's where I think you bring up a great point, in that I don't have the technology to use if it's not for you and your company developing it, and the engineers and the product developers and the salespeople who are good at creating that vision of why do I need that product. But then we work with them to then use that technology. And ultrasound has been around for a very long time, but now we've created ways to use it with, again, point of care ultrasound or regional anesthesia. Some of the pain management techniques, the two biggest barriers to ambulatory surgery have always been pain management and nausea and vomiting. Those are two of the bigger barriers, and the biggest in anesthesia care. Mm-hmm. And this has allowed us to improve that. Some of the innovation, some of the drugs, the pharmaceutical innovations that have occurred, and they are more expensive at times, particularly when they first come out, but they have allowed us to advance that ability to reduce nausea and vomiting postoperatively. Same thing with pain management and ultrasound. Now the nerve blocks, compared now to what they were 25 years ago when I was a young physician, there's no comparison. They are so incredible. I just took care of a friend recently who had a rotator cuff repair, which can be very painful. And he had one done a number of years ago, very painful. He had a catheter placed under ultrasound guidance, mm-hmm. and he basically had almost no pain perioperatively and postoperatively. And so really, again, these advances, but it's working together with the engineers, with the administrators, with everybody. We all have to be in this together.
Yeah, let's come back to a point we mentioned earlier, which is this broader shift of moving more and more from the hub, from the basement of the hospital, whether it's imaging or from the OR, and making it more accessible in an environment that is ambulatory, making it more integrated into the community, and maybe also through that process, starting to treat the patient a little bit more as a consumer and perhaps less of a patient. How have you seen that evolve, both in your journey in setting up an ASC, but also now coming back into a major health system? Is this an undertaking or a direction that the Wexner School and Ohio State is leading within your community in Ohio, in Columbus?
Yeah, again, another very insightful question. One of the things when we started our ambulatory surgery center, these were not really in the mainstream. Mm-hmm. And what really created our success was word of mouth. And word of mouth really, and what we know is that at the time, we had a very large percentage of pediatric patients that we did surgery on in our surgery center. We had about 60% of our cases were pediatrics, just by numbers. They were shorter cases, so the numbers were larger, but the longer cases were more adult. But the consumers who choose where to take their child are the mothers, and that's word of mouth. At the time, a lot of the social media was in its infancy, but they were on things like Facebook and they were talking to each other. Mm-hmm. So that really creating that environment where you provide high quality, safe and efficient care is critical, because you can have all the word of mouth you want, but if you don't have high quality and safety, it's all lost. And we really were very focused on making sure we didn't spare money to create margin and then not take good care of patients. And again, we were leaders in some of the new innovations and utilizing those as we were going along, knowing that there was a cost to that, but there was a real tremendous benefit to our patients. And now when I talk about video laryngoscopy, that has really changed the face of anesthesia care, because it's really improved what we can do in all settings. Mm-hmm. So that part of it. Now, as we go forward, yes, at Ohio State, we are actively driving the ambulatory surgery center model. And really a big part of that, again, innovation is going to be very important for that. And innovation from a software standpoint, predictive analytics and AI and I've got a big project that we're just starting now. I'm partnering with engineers in information technology who can help us to drive this, and we can help them with our clinical knowledge and really determine who is best suited for an ambulatory surgery center, or what is the best place to do somebody's surgery based on their comorbidities, the surgery we're doing, the surgeon who's doing the surgery, where are they, and the payer mix. Because we know, for example, that some surgeries, commercial payers will pay for in an ambulatory surgery center, but government payers, Medicare and Medicaid, won't. Mm-hmm. So knowing that is important too, so that, again, we can take care of patients in the best way, but also preserve the margin. So creating this predictive analytics and AI system and model is really important for us, because we are doing well over 60,000 cases per year in our health system across many platforms, both hospital outpatient departments, and ambulatory surgery centers. So it's really important that we get patients ready appropriately and determine what is the best place to do them. And I feel like innovative new developments in information technology like AI and predictive analytics are really a key component of that, particularly for big health systems like this.
Very interesting to hear how you've applied technology in surgery for both pre-procedure, choosing the right venue for the procedure, for the payer mix, for the comorbidities, the right patient, kind of investing in, the decision up front on like the right tool for the right job, then introducing technology into the OR itself to make the procedure more seamless, safer, and then also post-procedure, like you're discussing, for example, pain management, allowing rehab, being much more focused in how you're dealing with pain, which I know has been a big topic, especially in kind of this post-opioid world, right, where we're thinking about how to have like as much harm reduction as we can in the recovery process. Yeah, that really is fascinating. And kind of as you think ahead of ambulatory surgery, where is it going? Is it going even further, more into the community? Is it going further into more automation? You talked about robotics. Just maybe give us a bit of a future lens as someone who's seen this evolve now over the past 3 decades.
Yeah, it's a great question. We're actually in the process in our own organization of determining when and how is the right way to introduce robotics into ambulatory surgery, because we are doing already in our hospital settings robotic surgery on patients that really get discharged several hours after their surgery. Mm-hmm. But again, we have to look at, and this is, again, we're partnering with our administrative colleagues. It's important because there's a cost associated with it. It's very high, the cost of doing it. But if we can take it out into the community and offer that to people where they live, near their home, and they can have that surgery, because one of the things that we know too is that it's a big university, and you come to the medical center, and for people who don't come here all the time, it is very intimidating. It's large, it's confusing at times, and construction will move things around. Oh, I went that way 5 years ago. I can't go that way now. What do I do? So if we can take it out into the community and they can go to a really nice new place close to home and it's much smaller, that's important to them. And again, these technologies will help us to do that, and creating a model along with our business partners in healthcare to make sure that we can, again, there has to be a margin. Otherwise you can't keep the doors open. So just to say, well, we're going to do whatever it takes to take care of patients is really very myopic. And we need to make sure we can, again, that mission is supported. So we are doing those kinds of things, and we're right in the process of that right now.
Very interesting. We've covered so much today. We've covered your journey, starting as a clinician, an entrepreneur, focusing on leadership, and really working throughout your career to synthesize all three. And then we've talked about how generally healthcare leadership has evolved. I think you've talked to us about some really unique points about the role of physicians and clinicians as leaders, and how do we eliminate that schism maybe between administration and the physician leadership, and ultimately find better ways to work together. And then a little bit on where healthcare is going. And it sounds like more of it, even complex operative procedures, are moving more and more into the community, because ultimately that's where we'll have the best patient care. And also that's where we can have that sweet spot perhaps between the mission and the margin. So I've learned a lot from you today, Mike. Before we start to just bring this to close, if people want to keep up with you, where should they go? Where can they follow Michael Guertin?
So probably the easiest way is by LinkedIn. It's Mike Guertin, MD, MBA on LinkedIn. That would be the best way. If people wanted to email me, it's michael.guertin@osumc.edu. And I'm always interested in meeting people who have ideas and who would like to talk about things like this because, again, leadership is something that, and if you'd have told me 35 years I started my career that this would have been the path and I would have been in this leadership and leadership development, I would have looked at you like, what are you talking about? I would have had no idea. Again, life is what happens when you're busy making plans. And so I would be happy. And I always, when I talk to people, I like to, remind them of that and also learn myself. Maybe there's something else that I haven't thought of. My next journey is as a coach, and I'm going to get my coaching certification. And that's an important part too. And again, something I never would have thought of even 10 years ago, but I'm always happy to talk to people and learn from them. And if I can impart some of my experience and insight for them, that's a win-win.
Well, I certainly learned a lot from you today, Mike. I really enjoyed our time together. I would love to keep in touch. To all of our listeners, thank you for joining us for another episode of our podcast. That's a wrap.